Hi everyone, my name is Delaney Hart. I am the Infectious Diseases PGY2 Pharmacy Practice Resident at Abbott Northwestern Hospital. Today I will be discussing my major project entitled Pre and Post Implementation Analysis of EPIC Saved Work Functionality for Antimicrobial Stewardship. A bit of an overview of this project. The Abbott Northwestern Antimicrobial Stewardship Program was originally implemented in 2009. Since its implementation, EPIC has become more advanced with further opportunities to improve stewardship activities. One of these opportunities that I looked into was the use of the saved work functionality within EPIC. So this allows a user to save orders for review and activation by a later clinician. The use of this function by the stewardship team was implemented on November 3rd of 2020 after being approved by Abbott Northwestern's Antimicrobial Stewardship Committee and P&T committees. The goal of this private program was number one, to look at the percentage of repeat interventions to see if we are saving provider time and pharmacist time. Secondly, we also looked at the acceptance rate of stewardship interventions, provider feedback, and the number of interventions that were performed, with the goal of this program to be to save provider and pharmacist time, to ensure accurate order entry, and also to decrease the duplicate recommendations that are made by the stewardship team. This was performed via a retrospective chart review. The pre-implementation period was from April 1st of 2020 through November 2nd of 2020, and the post-implementation period was November 3rd of 2020 through March 31st of 2021. I looked at patients that were at least 18 years old that were reviewed by the antimicrobial stewardship team at Abbott Northwestern. Notably, we did exclude patients that were admitted to the ICU at the time of review because we perform handshake stewardship for these patients. Of the 1,490 total stewardship interventions that were documented during this pre-specified timeframe, 1,233 did meet inclusion criteria, as you can see here listed in Figure 1. 1,170 of these were prior to implementation and 657 were after implementation. As you can see, prior to implementation, 84% of interventions were accepted and 4 repeat interventions were documented. After implementation of this program, 89% of interventions were accepted and there were no repeat interventions documented. We also sent out a survey to hospital physicians, a voluntary survey to see what they thought of this program. And 27 hospitalists did fill out this survey. As you can see outlined in figures 2, 3, and 4 are their responses. The first off, we did ask if they had seen these saved orders. Around 50% said they had seen them. The second question we asked was whether they signed the saved orders. In other words, did they agree with the recommendation that the stewardship team was making, and did they want to make that intervention? Of the people that did see these saved orders and acted upon it, over half of them did sign the saved orders. And then the last question was, did you find these saved orders useful? And over 50% said yes, they did find them useful. And then about 40% said that they found them somewhat useful, with about 10% saying no and about 10% saying other, and they gave some feedback. So some of the select physician feedback that I looked at was, one person commented that they had not seen this yet, which is not surprising considering the smaller time frame that we did look at of about 3 to 4 months. But they said they did find that it would be very helpful. The second feedback was that it was a well-intentioned program, but they specifically think it would need some time for a majority of hospitalists to buy into this, stating that specifically in their own practice, they're earlier in their career, so they are always double checking and verifying drugs anyway. So they didn't think that it would save them a ton of time at this point. And then one of the last feedbacks that we had was they said they felt this pilot was a good plan because they don't have to depend solely on the Dear Doctor notes and then have to go and translate what was written in the Dear Doctor notes into writing their own orders. So they do think that this really provides the best patient care for patients. Some limitations of this study were that the pilot program was not done across all hospital units. As I stated before, the ICUs were excluded. The second limitation was it was really difficult to quantify whether time was saved with these repeat interventions based on the documentation that was available at the time of chart review. The goal of this project was to see if Pharmacists were still having to make repeat interventions, such as recommending changing to an oral agent and adding a stop date and only having one of these tasks performed. The goal with the saved work was if they could enter the order for the oral agent with a stop date in place, they wouldn't have to go back a day or two later and repeat the recommendation. Unfortunately, with how Epic is allowing us to do documentation at this point, it's very difficult to retrospectively look at whether time was saved or not. But overall, a majority of providers that had used the saved work functionality noted they found it was useful or somewhat useful. And we did see a statistically significant increase in provider acceptance rate after the implementation of this saved work functionality. Although it's unclear at this time whether the pilot saved provider or pharmacist time, the antimicrobial stewardship team intervention acceptance rate did increase, and overall feedback from the providers was positive.